Good afternoon, and thank you for joining us for today's presentation, Master Planning in the Healthcare Reform Era. I am your host, Sergio Aranda, Marketing Program Manager for eBuilder, and I have the pleasure of introducing our speaker, Mr. Curtis Skolnick, Vice President with the KLMK Group, a consulting firm providing strategic master facility planning, organization and project assessment, project launch and gap analysis, and project controls development. Curtis has over 18 years of healthcare strategic and facilities planning experience. His expertise lies in project launch gap analysis, market modeling, system and new business development, strategic planning, capacity analysis, master facilities planning, functional and space programming, and government and regulatory affairs planning. His project experience includes work with Upper Chesapeake Health, Martin Memorial Health Systems, C.B. Sumter Medical Center, Washington Hospital Center, and Memorial Hospital. Curtis has a Bachelor of Science in Healthcare Management and a Master of Health Administration, both from Virginia Commonwealth University, the Medical College of Virginia. Curtis will provide us with some background information on healthcare reform and its impact on ongoing master planning activities. We will also have a discussion on the need for strategic master facilities plans, typical strategic master facility plan process, scenario modeling approach, and we will leave some space in the end for final thoughts and Q&A. Curtis, take it away.
So what is healthcare reform? Mentioning the debate, I don't know if anybody had a chance to watch it last night. I'm sure a few of you did, but I was a little disappointed that it didn't come up more. You know, considering that it's 18% or around 18% of our gross domestic product, and roughly 10% of our entire workforce is some way tied into healthcare, I thought it would come up more last night. It came up briefly here and there, but not as a big portion of the debate, although it did come up a few weeks ago. But there's still a lot of questions. People are still scratching their head, and there's a lot of uncertainty, even though the law is being enacted. And there's elements, we'll get into that here in a moment, that are being enacted. There, you know, full-scale systematic and systemic changes may take a generation to fully take hold. It's going to take a while to change referral patterns. It's going to take a while for payment reform to really take hold. Depending on the types of payment reform we're talking about, I'll get into those in a moment, it may take a while. And, of course, post-presidential election, things could change again. And, you know, it begs the question a lot of times, do we really have a healthcare system in the United States, or do we have a bunch of disparate yet organized individual entities that circulate in the same orbit? So there's a lot of debate about what our healthcare system really is here in the U.S., and that's not a new debate. That has been something that's been going on for decades, as you know. This is a slide that from some information from healthcare.gov. Key features of the Affordable Care Act by year. It's a pretty good website and gives you a lot of information in a short few slides. But really what's occurred over the last several years is we've gone to new consumer protections and are now focusing on improving quality and lowering costs. Everything from disease prevention and illness to managing healthcare fraud. If people are familiar with the RACs, the rate audit contractors, you know, current efforts to fight fraud or return more than $2.5 billion to the Medicare Trust Fund. You know, that was back in 2009, 2010 alone. The new law invests new resources and requires new screening procedures for healthcare providers to boost those efforts. And some of you who are in hospitals today are feeling the effects of those RAC audits and challenges to short stays, especially. There has been obviously a large focus on improving healthcare quality and efficiency. The law established the new Center for Medicare and Medicaid Innovation that tests new ways of delivering care to patients and looks at new patient mechanisms, you know, specifically looking at value-based purchasing agreements and bundled payments as ways to enhance and allow healthcare systems to hopefully control their costs, or encourage healthcare systems to control costs. Bundled payments for an episode beginning beginning 3 days before the episode of care, and any 30 days after the patient is discharged, is something that's been piloted, or is being piloted, and as of January 1st, 2013, that'll be a big deal. One of the goals is ways to correct current fee-for-service. I don't think fee-for-service will ever go away, but certainly the more fee-for-service is at risk, and hospitals are budgeting for that. So it becomes not a question of revenue, it becomes a question of being able to control costs as a way of enhancing revenue. We're linking payment and quality more and more. Just this month, just a few days ago, or October 1st, we actually had a portion of the law take into effect that limits the amount, limits potential reimbursement for certain readmissions back to the hospital. And that's a way, again, of controlling quality. Not all readmissions are excluded from reimbursement, just certain ones, but that's up to audit control as well. Certainly, as we move forward, we're encouraging integrated healthcare systems in this country through either accountable care organizations or through medical homes. And that's been effective this year, although it's still a little bit confusing out there in terms of just what the returns are going to be and what the mechanisms are going to be from an ACO standpoint as to how people actually get reimbursed. But certainly these things are taking hold, and the medical home model is starting to take hold with primary care providers all over the country. As we move forward into 2013 and 2014, we're expanding the authority to bundle payments. Mentioned that a little bit earlier. But under payment bundling, hospitals, doctors, providers, paid a flat rate for that full episode of care, rather than that current fragmented system where each service or tests or bundles of items or services are billed separately. So it's going to cause us to basically get one payment for a variety of services. We've tried this before. We'll see if it works this time. And then, of course, what's been getting a lot of talk and a lot of press all around, small business tax credits, increasing access to Medicaid, and promoting individual responsibility. That's probably the most controversial element of the law that takes effect in 2014, where most individuals who can afford it are required to obtain basic health insurance coverage, either through their business or through affordable insurance exchanges. If they can't, they're going to be charged a fee, or as some people call it, a tax, depending on your viewpoint. So that obviously is a controversial piece of the law. But I think one thing that is clear throughout all this is personal accountability for one's health. I was reading an article in one of my wife's magazines. She's a nurse, anesthetist, and looking in one of her magazines, they were talking about the difference between adhering to your care versus being compliant in care. And we've always talked about care compliance, and that has a connotation of a one-way street where the caregiver says to the patient, you will do this, and then they come back 30 or 60 days later and it finds out that the patient was non-compliant, versus really truly adhering to the care plan and having the family and the patient be a partner and take an active role in that care plan, even to the degree of allowing home health and home care visits by physicians to actually check out somebody's home, visit the home, make sure that the diabetic patient, for instance, is actually taking their medications, look into their cupboards, look at the diets they're under, and really help manage the health of the population. And that's what a lot of reform has been geared towards. The Institute for Healthcare Improvement has discussed their AAA initiative, and that's been adopted in large by CMS, and it's a key element of what we're trying to do here. And it's really about three things: improving the patient experience of care, and that's quality and satisfaction; improving the health of all populations; and then somehow reducing the per capita cost of health care. And before you know it, we're going to be at 20% GDP here in the United States, and that's a very sobering figure, considering just a few years back we were in the lower teens. A key element of all this, and if anybody recognizes this picture, that's Robert Young from Marcus Welby, but it's a key element of Triple Aim and the Affordable Care Act. It impacts how and where care is delivered, and also, again, complements this notion of ACOs or medical homes. The medical home is a way by which your primary care physician manages your entire episode of care, and an ACO is a way that that again a healthcare organization made up of payers, physicians, providers gets together and helps manage your entire episode of care or your entire episode of wellness. What we're trying to change towards here in population epidemiology and management epidemiology is really changing towards a system where we manage wellness and not necessarily manage illness. Some people postulate, is this a return or the demise of the Marcus Welbys of the world, the single practitioners that make house calls? Some ask, is it the return? Are we going to allow our physicians back into our homes? I think this happens overseas quite a bit. In France, I was talking with my colleagues, quite a few physicians make house calls. And I believe up in New Jersey, there's a health system in New Jersey that has piloted a program by which they send physicians out to the community, especially Medicaid patients, to see if they're adhering to their care. Again, not complying, but really adhering to their care. And, in managing those wellness and chronic conditions, where the goal is to try to improve health overall, and again, manage wellness, not manage sickness, to avoid visits to the ED, avoid visits to the hospital. My father, personal experience, is diabetic. He spent 5 weeks in the hospital a few years ago, and that was a significant moment in his life. It spent a lot of money, took a lot of resources, and was just obviously a dissatisfier for him. We feel that if his wellness was managed versus his illness, it would have been a different situation. And I'm happy to say he's doing much better today and well on the path to managing his diabetes. But things like diabetes, CHF, hypertension, COPD, those things need to be better managed. That is what's taking the lion's share of our cost and our time in healthcare. Those chronic conditions, those medical conditions, but also as well don't make a whole lot reimbursement-wise. It's those procedure-based things that are more episodic in nature that make the money by and large in the United States. Some people have been piloting these programs. Health Partners, which is a medical group in Minnesota, about 700 physicians, 24 primary care clinics, 9 specialty clinics. They've been able to reduce utilization and cost just by managing the health of their populations, the patients they provide, by setting up a medical home. They've seen double-digit increases in patients receiving optimal heart disease care. They've seen triple-digit increases in patients. I'm sorry, a 350% reduction in appointment waiting time. They've seen almost a 40% decrease in emergency room visits for their patients, and they've seen a 24 to 25% decrease in admissions. And that all sounds great. And that's wonderful for our own well-being, for our loved ones, and for the general wellness and health of the country in general. But when you work at a hospital or for a system that is reimbursed on a per-click basis, and that makes budgets based on growth for people walking into a hospital and taking care of those patients, it has a different effect altogether. Utilization is down all over the country. And in most parts of the country, there are certain pockets where utilization is up. But in Houston, for instance, there's been, I believe, the number of beds there that's been calculated. There are about 300 or 400 additional beds in the system that are not needed and are not used on a daily basis. Memorial Hermann, I believe, accounts for about 2,000, 2,500 of those beds, and about half of those beds on any given day, on average, aren't utilized in one report I read. So it's pretty sobering to think that as our facilities continue to age and we need to reinvest in our facilities, is where's that next piece of revenue going to come from? So what does it all mean? All this means we're going to have an increase in access for consumers, but through what portals? Is it through a hospital, as traditionally through the hospital ED, or potentially an outpatient location, or through the medical home? And again, what's the impact on utilization? We might see utilization overall go down on an inpatient basis, but actually go up and continue to go up on an outpatient basis, and through our primary care providers. And what's the timing? And these things are taking effect now, but again, I believe it's going to be a while before we really truly integrate all of this into our healthcare system. And I mentioned some initial results through health partners and others. That we do see some initial results. We have seen costs start to come down as health systems, and I'm talking integrated health systems, have started to organize themselves around really truly becoming more efficient in the way they deliver care. And my last point there in terms of health system consolidation, we have seen we talked about the demise of Marcus Welby. Is there also a similar trend occurring with the independent hospital out there? Most areas of the country where I work, the system or the geography is controlled by a few health systems. Northern Virginia, for instance, has a few major health systems in and around the D.C. area, as well as players coming from as far away as Hampton Roads in North Carolina jumping into those markets, and to try to basically gain market, but at the same time also leverage costs and spread costs across the system. The center of the world, healthcare world, may no longer be the inpatient chassis. On a project I'm working in, we've often talked about the hospital on the hill, but is it more realistic to have more real estate, more patient care occurring off of the main hospital campus? With the exception of academic health centers and large or in rural providers, single rural providers, I think you're seeing this trend continue. This has obviously been a trend towards outpatient, but as the high-cost center of the universe is typically the hospital, you're seeing more and more care occur off the hospital campus. Yet we have to invest in our inpatient chassis. Hospitals are trending to be health centers that just happen to have beds. Outpatient in nature. They look and feel and they operate as outpatient centers. They just happen to have beds. And there's obviously been a focus on observation and short stays, and the cost structure, but that's payment and cost structure driven. There's been a lot of discussion around how do we manage the emergency department. Are we going to open ourselves up to a flood of emergency department patient visits? There's already been some trend to increase an increase in emergency department visits over the last decade. That's softened somewhat, but as we open up access, emergency departments are asking themselves more and more: are we set up to handle this workload? And do we want to spend capital dollars in either expanding or retooling our EDs, or is it really something we got to do in terms of workload throughput mechanisms and get people through the system and change the way we deliver care in the ED versus building more and bigger EDs? Of course, there's always a competition for capital dollars. There's quality-based incentives. We're trying to move the industry forward with things in IT, electronic health record, another provision of the Affordable Care Act. Looking at different partnerships. There's medical staff alignment dollars, recruiting new physicians. There's strategic capital people are spending in terms of developing new services and programs. There's operation improvements, lean processing. People are spending money on that. There's service development, research, education, and then, of course, facilities. So it used to be facilities took up the lion's share of our capital dollars. Now it's spread through a bunch of different buckets. And the CFO is the most powerful man or woman in the room these days in terms of how those dollars get allocated. System consolidation has changed the game, as I mentioned earlier. Excuse me while I take a sip of water. But, what this is causing people to, and I've been saying this for years, and I actually added one in here. I've been saying for years that a facility project is an enabler of a strategy. And it's not a strategy in and of itself. It's a tactic. And it projects must address, it used to be 3 things, I added 1. It used to be strategic needs, infrastructure, and mission-driven, but I also had standard of care issues. We're seeing facilities that are aging, so obviously, physical plants, boilers, chillers need to be replaced, and upgraded roofs need to be replaced. We're seeing strategic needs and program elements drive changes in healthcare, whether it be hybrid ORs, private rooms, larger rooms, private NICUs, you name it. And then, of course, mission-driven initiatives. I'm a sole community provider that has to provide psychiatric services and behavioral health care services, so I need to be continuing to develop those programs. But also standard of care in terms of being able to meet environment of care standards set forth by the Joint Commission and in our own design guidelines. And as there's more and more emphasis put on ratcheting back reimbursement for readmissions, and positively reimbursing for positive impacts to quality, those standard of care issues are going to become more and more prevalent as we walk through our facilities and see areas where we might have the opportunity for things like nosocomial infections or fall reduction or materials that may lead to injury or even death in some cases. But we got to build growth. We also have to build in flexibility and growth in different ways. Expansion zones versus shell space. Not a lot of money being spent on shell space these days. We're looking at ways to expand the facility. So if we look at our master plans, it used to be we would say, we know that utilization is going to go up. Let's plan a shell floor. Now we're seeing people who are actually taking space out of the facility and taking program out of the facility and realizing, we either take a floor out, we leave it as shell, or we just take it out because we can't afford the first cost, but let's make darn sure we know where we're going to expand and expand quickly if the world turns a little bit. And that typically tends to be a horizontal approach and not a vertical approach unless you're in a downtown environment. We're seeing more and more universality versus specialty, and that means more common structural grids built on a 28-foot basis or even a 30-foot column grid basis as a minimum. And we're seeing rooms, ORs, that are being built to a certain size to accommodate a variety of specialties. 400-square-foot ORs just don't cut it anymore for a lot of what it takes for most complex cases. We're getting smarter with what we're putting in the rooms, so we don't need 800 and 1,000-square-foot rooms overall, but certainly 600, 650-square-foot operating rooms to be able to handle any case that comes along the way, and any specialist you might recruit is becoming the norm. Same thing in the inpatient bed area, or being able to shift out and use a cath lab, for instance, and maybe convert that to an OR or another interventional room down the road. We're taking creative approaches. We're seeing more outpatient-like hospitals. Gone in a lot of our projects are the large, lobbies and monumental staircases, by and large for our community, 100 and 200 bed hospitals. So they're becoming more of an outpatient feel where it's based on function, flow, practicality, and flexibility. Business is being driven, and I say off campus, we're redefining where the campus is, but being driven away from the main hospital into lower cost and easier to access environments. And again, we're going from wellness and chronic versus sick and episodic. So it's managing wellness, managing those chronic care patients who take up so much of our resources, and trying to keep them out of an episode of care versus managing sick and high-cost episodes, for instance, like my father's 5-week stay a few years ago. And, of course, we're taking creative approaches to design and construction, and you all, most of you on the phone, deal with design or construction every day. So you've seen some of the creative things that people are doing in terms of flexibility and fungibility of space, being able to stack like elements, being smarter about mechanical chases and IT chases, so you don't have to come back and retrofit a year after the hospital is open. Let's jump a little bit into master planning. Our philosophy is that it's a holistic approach, and it's not just about that purple circle there defining the physical environment. It's first about strategy, and it's the why. It's the what and the why. It's the market analysis and what services I'm going to be providing, and how much of those services am I going to be providing. Where am I going to be providing those across my continuum? And that gets into defining the care delivery model, and its operations and flow. So, we've talked people out of building certain things because we've seen an opportunity to be able to change the operations of a certain area, and in that way effectively open up capacity without adding a square foot. So it's defining how the care is going to be delivered and how system synergies, change the way, and those things need to be built on campus, things like labs or pharmacies or distribution centers that can serve an entire network of facilities. Then, of course, it's defining the physical environment. We're really doing a quality assessment prior to the solution for the master plan itself, understanding what the limitations and the constraints of current physical facilities and sites are. It may make more sense to replace a facility than it does to renovate a facility. In some cases, it's quite the opposite. But all those need to be studied prior to jumping into a detailed plan. And I'll get into that more in a moment. And of course, financial analysis. Everything's got a pencil nowadays. Again, the CFO is that most important person in the room. And making sure that these projects have a positive return on investment, or at least are cost neutral, and are not going to lose money over time is becoming more and more important. It's always been important, but we're finding these margins razor thin these days. Whereas, a few years ago you could say, yeah, we'll draw 6 or 8% margin on that. Those margins are definitely decreasing because we've changed the reimbursement side, but haven't changed the cost side. And then, of course, understanding how regulatory controls might impact your master plan, things like certificate of need. I mentioned down in Houston, for instance, they're way overbedded. Talk about some locations in Virginia that are similar in nature, and trying to add capacity to a physical plant when you've got unused capacity in the healthcare system is very difficult to do. And then, of course, understanding zoning controls and other authorities having jurisdiction. And I'm not going to read all this to you on this next slide, but typically over a 6-month process, 8 months, depending on the situation, you're going to go through a pretty typical process to define your master plan, where it all starts with an organization assessment and strategic planning and validation. I know there's a lot of you on the phone who go through this process, but there's probably some of you that don't, that say, I need a building, and I've just recruited a new physician or a new set of physicians that want space. So you jump right into the facilities development and options development. What usually ends up happening then is you've got to circle back to those first couple of steps. But this is a pretty typical approach. Takes some time, but it's usually pretty well received if you have a facility or a system that understands that they have some money available to be able to spend if there's some very critical needs, and has done some upfront planning, really. If you haven't done some upfront planning initially, there's probably a different approach. And that's what we've been calling a scenario planning approach. It's more of a high-level assessment, and it's geared towards achieving some sort of options you can present to those your decision makers. And before you move into detailed planning, it's typically this may be a 2 to 3 to 4 month process at the max to study high-level scenarios. So rather than get involved in that detailed master planning exercise early, the hospital organization should develop those scenarios around each broad renovation option or replacement option, and identify the pros and cons of each. There's things like first cost, life cycle cost, disruption to existing services, strategic fit, return on investment, optimal operations, CON, regulatory issues, etc. And develop an order of magnitude total project cost opinion for each of these scenarios, and try to narrow down a bunch of options. Most of you who've been through these processes realize you probably, when you start talking about a project, you may have a dozen options that come out of the woodwork. We're trying to narrow those down to a few palatable and realistic scenarios to present to the hospital leadership or to your hospital board, so they can make an informed decision and say, am I willing to spend X $100 million or $50 million in a project of this magnitude, and am I even willing to spend the planning dollars, knowing that, again, people have cut back on consulting costs, design costs. Am I willing to even spend the consulting dollars and the design dollars to move forward on this project if I don't think it's going to give me the proper return or it meets our organization's strategic needs? So you give the owner, which is most of you on the phone, a way to make an informed decision prior to developing those detailed plans. And it also helps get the team focused around a few palatable scenarios, and rather than spinning your wheels too much on scenarios that don't meet satisfactorily those institutional goals. And we break this down into a few phases, and it's pretty similar to a master plan, just at a little different high level, where it's initiation and discovery, where we or you internally should gather all the information you can, have one person or a group of people who is responsible for collating and compiling all that information, and maybe even saving it in a system like eBuilder. But interview your stakeholders, talk this thing up. The worst thing you can do is try to develop these plans in a vacuum, and talk about what those capital project success factors are, and what the conditions of satisfaction, to use a lean term, are going to be. How do I know when we've defined success? And then meet with your facility planning team, whether that's an internal or external group. Try to engage as many people as you can where it makes sense. But don't go too deep into the organization, as you'll want to manage expectations if a certain scenario doesn't work out. And that's when you get into, once everybody's kind of singing off of the same sheet of music, you're going to get into visioning and some initial development. So I'll show you some questions here in a moment that we typically ask. And then you get into identifying options and developing a project roadmap. So got a funny story. People say, what's the high-level view? I want to be 30,000 up. And on the left here, out of an airplane, and if anybody saw that guy a few days ago jump from 24 miles up in the air, that was something to see. But that's Felix over there on the right, Felix Baumgartner, jumping out of the balloon. But a few years ago, I was working actually I was in-house and working with the CEO on the strategic plan, and he wanted to keep it very high level, and he said to me, I said, hey, let's keep this at 30,000 feet. And he said, no, I want to go higher than that. I want to keep this up at a mile. And I said, yeah, you know that a mile is like, 30,000 feet is like 5 miles. And he's like, yeah, whatever, I get your point. So the point is, keep this thing high level initially, and develop these scenario plans, and give yourself a roadmap, and talk about things like vision. What improvements am I trying to make? What's our market strategy? Who are our stakeholders in all this? Do I have the stomach for something that may take 5 or 6 years to implement, or do I have to get something off the ground in 2 or 3 years? How much money is it going to cost me? What's our site strategy? So as we go through these and we discuss with our clients, or if you discuss these things internally, and we've learned from our clients as well, is ask yourself the question: what future are we really trying to plan for? Is it just moving the organization forward in the way it's been for the last 50 years, or is it really trying to take a different approach in the way it's delivering care to respond to healthcare reform and ACOs and medical homes? It's going to require a different dynamic in the way our system works. And also ask yourself, what is the vision of the organization? It might be for a specific project, so what's the vision of my Heart and Vascular Institute? But it may be more of an overall overarching question. What is the vision of the organization? How will that drive a facility scenario? A question I like to ask, and this is always a good one and always a fun one that gets good discussion, is what's the identity of the organization, and how are we trying to enhance or change that identity? Are you a high-tech, high-intensity research an academic organization like the Mayo Clinic, or are you more hands-on, high-touch, and all about service? You can have both. They're not mutually exclusive. You can have both. But people will usually say, yeah, I love that place because it's got the latest and greatest equipment and the best doctors who are trained who are always ended up first in their class. Or you'll see the flip side. People say, I just get great care there. I love the people. They're caring. It's clean. It feels like I'm at home. And there's a way to have both. But understand your identity. And are you trying to change that identity or enhance that identity? Sometimes partnering up with a system makes you change that identity or change your culture. It's very much a cultural phenomenon. But ask yourself that question. It's usually a very interesting question and will help guide you on your path through strategic master facility planning. And ask yourself, what improvements am I trying to make? Obviously, we're probably trying to control costs, change throughput, change the care environment, better the environment of care as we discussed earlier, make infrastructure improvements. But what's the most important thing on the list as you develop a $250 million master plan and you start to chop those into $50 million buckets? Which are the most important things on your list to solve? Is it getting out of an old building, or is it providing for a new service that's going to give you a positive ROI? Those are hard decisions and hard questions to address. So understand what you're trying to do and why. Also ask yourself what plans have been made to date. People will typically take things or plans off the shelf that were done 2 or 3 years ago. And much like our iPhones and technology and healthcare technology, the way we're addressing facilities and flow and throughput changes year after year after year. So what may have been on the shelf a few years ago from a master plan may have to be validated and refreshed. You may have new leadership in the organization, so you have to ask yourself, how wedded are we to plans that were done a few years ago? And they may still be very valid. So at least validate those, walk through them, because there's probably still a lot of good work that was done from those plans a few years ago that you can translate and update. So refresh it as needed. One question I mentioned earlier was how does a system partnership impact planning as we're going through more hub and spoke type models? Are we just a bunch of loosely organized organizations that, again, happen to travel in the same orbit? Or is there a way to share services centrally that help us cut costs, not only operationally but facility-wise? If I have a hospital that has a flagship, a 1,000-bed flagship, and has then multiple 200-bed or 100-bed facilities, can I have a central lab that services all those? So I don't need to build the large reference lab at each facility. Do I have a central distribution center? Most of you probably already do a lot of this, but do I have a central D center that allows me to then manage my supply chain in a different way than I would manage it if I were serving people or hospitals individually? Even things like administrative support, marketing, IT, education. How are those handled at a system level? And are there any savings I can make either operationally or not having to build new office space for administrative staff who are very rarely at the hospital site? Or do I build those in a different type of construction altogether that happens to be on the hospital site, just not an institutional grade construction? So looking at those things creatively is the way to do it. There's many more we could go down, but again, it's saving money now versus generating additional revenue. Additional revenue is going to be hard to come by in today's day and age unless you're in an area that just happens to be insulated from all of this. I don't know where we'd find that, but certainly in some areas there's still a high level of and a high rate of growth population-wise, but in a lot of areas there's growth is stagnated, and that coupled with use rate declines and length of stay declines, as well as payment reform changing us from a per-click basis to a more capitated environment that's based on bundled payments, is going to change the way we really look at things. So it's all about managing cost as a way to quasi-generate revenue and add dollars to the bottom line, so you can afford to do some of these non-strategic projects, some of those infrastructure and standard of care projects. Just a brief case study. We did some work at a system that was looking at partnering with an independent hospital. This made this system then 2 large hospitals with 2 smaller inpatient and older facilities. The independent hospital had a master plan developed, and the system facilities needed some updating, except for a facility that was built not too long ago. We asked these questions. How does a part of a system change those facility plans? Do they renovate or replace this independent facility? If you would have asked them before the merger, they would have probably had to, probably would want to replace it, would have had to renovate given capital constraints. Now it opens up the question a little bit differently. And do we upgrade or consolidate our smaller and aging system facilities across the enterprise? So the hospital, the system validated that scope of that master plan, looking at assessing the best use and approach for that independent facility. You looked at things like operations, unit bed size, growth, cost, et cetera, as a 50, 60-year-old facility. And could you really do on campus what you could do in a greenfield? The answer was no, but did we have the time or the capital resources available to build a greenfield facility? That's a big question. We factored in market and shift to services amongst all the operating units, and looked at developing order of magnitude cost options. I had someone call me a bunch of years ago that said, hey, Curtis, we want to open up a new facility. How big and how much? And that was the extent of the question I got. And I said, well, you got to give me a little more to go on here. So we had to help define it, but we didn't need to get into a deep master plan to do that. We had to look at made some initial high-level assumptions on beds, types of services, amount of ED visits, and then develop those order of magnitude cost options. So somebody could say, somebody said it was going to take $500 million to replace this hospital. Is that right or wrong? We might say yes or no. So if $500 million is palatable to the organization, but it's really going to cost $600, then this gives the organization a way to say, I then know I can't replace this facility because I can't afford it. So let's take that one off the table. Before we spend any more time on that option, let's look at other options of potentially doing something different. So at this particular system, we narrowed down those options to a few. We discussed all the pros and cons, and the leadership within 90 days was able to reach some conclusions, and information was presented to the board at a high level. I'm not going to read all of this to you. We looked at 3 broad options, and this was our presentation. This was it. This was the presentation that we made at the very end of the engagement. Now, there was also a site plan on the back of this, but this was an 11.5 by 17 sheet that we handed to some of the key stakeholders in the room and talked to them through this. We had a lot of backup material, obviously, and through the facility planning team, there was a lot of due diligence done. However, it became as simple as this, of giving the decision makers the ability to quickly assess how long, how much, and what are the broad options. So some final thoughts on all of this in terms of scenario planning versus a more rigorous and deep diving and higher cost strategic master facility plan. We feel if this is the way to go, this helps you narrow down options. And it really understands the basics, the cost, the scope, the duration, and then the why for all this. But keep it at that high level initially if you can afford to do so. Plan for the whole, but the parts should be able to stand alone. Again, if I've got a $250 million master plan that comes out of this, do I have 4 or 5 $50 million buckets that I say if I pick this portion of the plan, that can stand alone without having to do the other parts of the plan. That's a key element in all of this. And again, strategy, it's about infrastructure, it's about mission, and it's about standard of care. Make sure that any project is well rooted in strategy or some other need prior to moving forward. It shouldn't just be a want, it should be a need. So make sure that everything meets a need and not just a want. More and more people are saying to us, and I hear this all the time, I'm from Missouri on this, the show me state. So I'm from Missouri on this, show me why. Don't just tell me you want it. And then, of course, build in, and this is a mantra that we've been using for years, and you all have heard, I'm sure as well, is plan for change and plan for flexibility. It's hard to think about where we were 5 years ago in terms of how healthcare has changed. The next 5 years you're going to see as much change, so it's very difficult to get these plans nailed down with all certainty today when it's going to be a very different environment once facilities and renovations are made a few years down the road. So with that, I just want to say thank you again. I certainly appreciate the time you've taken, and here's my contact information. Open it up to questions and answers here in just a second. Hopefully I'll have some answers for you. There's my email address if you'd like any more information, like to talk more about this offline. You can also reach me on my cell phone. I'll give you that number. If you've got a pen handy, it's 804-512-0747. Again, 804-512-0747. Again, we can help you. You can do this in-house. Most people we find have the ability to do this in-house. But these are the steps, regardless of whether you use us or an outside consultant or you do these things in-house. We feel that getting that high-level assessment initially is a good path to take. You don't confuse high-level with a less rigorous amount of study and collecting a lot of information. With that, I'll open it up to questions. Sergio?
So, Curtis, I'd like to start off, and again, thank you very much. Want to turn it over to questions from the group. But in terms of some of the changes that you were discussing at the beginning and talking about healthcare reform, given the types of projects and all the different clients that you guys work with at the KLMK Group, have you seen any changes in terms of how they're actually managing this from the planning process all the way through capital construction? Can you maybe talk to that a little bit?
Yeah, we're certainly seeing people take a more collaborative approach, And rather than have, again, treat it as a system, and I've mentioned that a few times throughout this, and that's kind of a running theme for me, is treat it as a system and make sure that you take a holistic approach to this. We're seeing more and more people, whether it be a true IPD, integrated project delivery approach, or just merely a collaborative approach, by getting in planners in early, getting the strategic planners in-house involved early, getting the care team involved early, and making sure that all the different elements of the organization, from the CFO to the care team to the guys in plan ops and facilities, as well as if you needed to bring in an architect or a construction manager or a third-party estimator or an MEP designer, get those people in early. You spend a little bit of money up front, but you usually typically end up with a better product down the road if you take an integrated planning approach, in my opinion. And we've seen people employing that, factoring in lean teams as well, and taking a more lean approach to the way not only construction, but in the way they're actually running the teams, the big room concepts, for instance. So people are taking creative approaches, but it's more and more about collaboration and making sure you got the right information. It's easier to make changes and spend a little more money up front than it is when you got things actually coming up out of the ground. It's a heck of a lot harder to make changes down the road and realize you would have asked the question, a couple years before.
So as a follow-up to your answer there, and my question, are you going to see, or do you expect to see more groups turn to integrated project delivery to maybe mitigate some of the risks that these changes will bring?
Yeah, I mean, we've seen some change in that, and it's taken hold in different parts of the country, and we have a few clients that are using that approach with great success. A lot of times the IPD approach is also a contracting approach too, so that helps align incentives of the team. So if you want to get hung up on the legal mechanism, we don't need to do that today, obviously, but people, if they want to stop short of an IPD approach versus signing a tri-party agreement, we do see people, again, going towards an IPD light, where it is a very collaborative process. Incentives are aligned early. We have team alignment sessions where conditions of satisfaction and expectations and all those things we ask ourselves about what we want to do as healthcare organizations, that we ask the team the same questions in terms of the delivery team, are what are our guidelines? Make sure we're all aligned towards the same goals as we move forward. So yes, it's definitely either true IPD or an IPD-like collaborative type environment.
So somebody wants to know how much is IPD being used in healthcare these days, and talking for typical projects, not necessarily for master planning.
For typical projects? That's a good question. I don't know the exact number. I know we've had 4 or 5 of these in the last couple of years, and some ongoing right now. And they vary in size of project, everywhere from a replacement hospital all the way down to an ED renovation for a hospital we did in Flint, Michigan. So there is more and more acceptance of it. Again, the tri-party agreement sometimes trips up people's legal teams, and people sometimes are not ready. Organizations aren't ready to bite off that type of approach. What they will bite off, though, is that IPD light and take that more collaborative approach where the team is aligned. To make it really stick, though, sometimes you do need that tri-party agreement. So it's becoming more and more accepted. Some people on the West Coast are using it, people on the East Coast, but I don't know the exact number.
So, and as you mentioned, I think one of the key takeaways is that people are using it to one degree or another, and just because don't necessarily have an IPD contract in place doesn't mean they're not actually doing IPD.
That's correct. Well, yes. I mean, you can say they're doing kind of a collaborative or integrated model, just without the legal ramifications and tri-party agreement. And we're also seeing the collaborative efforts at the front end, where we're seeing more and more planners out there partnering with architects bringing in planners bringing in architects, versus trying to do all of this under, again, with disparate parties. So we're seeing more and more collaboration on the front end of these projects as well, which I think is a positive sign. These are tough questions to answer in terms of how where healthcare is going to move, and you need some really smart people in the room. And I'm typically never the smartest person in the room. There's typically a lot more smarter than I. So it's but bringing smart people together who understand their subject area extremely well is always a good bet to get a good project.
So somebody asked, an initial statement seemed to exclude AMCs. Can you summarize how adding an academic mission into the mix changes the scenario planning or HC reform response?
I think academics for sure are different, but I don't believe the questions are any different in terms of what the vision, what are you trying to do, what are you trying to improve. If the and I didn't mean to exclude academic medical centers, but they run a little differently. There's typically some political factors that go through academic medicine. There's research dollars at stake. So it's a little different than the community hospital down the street who's just trying to deliver care in a good way to the community they provide. Academic medical centers have that mission as well as an education mission, as we all know. So the questions just become a little more. The questions are no different. The answers just become a little longer and more involved. If I'm going to recruit a new physician and that physician has a faculty appointment, questions around where that person's space are different than you'd ask in a community hospital. So the answers are a little different, but the questions tend to be the same.
Now, somebody else wants to know how many healthcare systems are starting to leverage using CAFM with building information modeling becoming more prevalent these days.
Yeah, we just had our own internal lunch and learn on this last week, and I don't know the answer to how many are, but I know that more are. When you ask people if they use BIM or building information modeling, they say yes, and then you got to ask the deeper question. Okay, tell me how you use it. And some will use it for a Revit model and then class detection, but won't use it for CAFM or procurement or a way to manage the project down the road. So yes, people are. I believe, I believe BIM is going to be the standard, if it's not already becoming the standard in a lot of projects. And certainly being able to manage the facility, using CAFM through the BIM model is a great goal, and we're seeing more and more people do that.
From a strategic planning approach, Curtis, are you guys actually leveraging, the BIM technology, or to any degree, or is it not applicable at that stage?
Strategic planning, not at that level. Typically, no. I mean, at a strategic master facility plan level, you're not at the point yet where it makes sense to design using BIM. Now, there may be 3D modeling. You may do some SketchUp and so on, but to use BIM early on, probably not just yet. I mean, you'd use that as soon as you start, after you launch the project and bring on the team is when you're going to want to start using BIM. So we're not certainly using it at that early stage in the project.
So I don't see any questions coming in at this point. So Curtis, I'd like to take a moment to thank you very much for this presentation. As always, KLMK Group is always at the top of their game. You guys have a ton of information to share. I know you guys have a lot of resources that are available on your website, both related to, as you mentioned, strategic master planning, integrated project delivery. So I will encourage our guests, and I'll be happy to share some of those links as well, directing people to your website for some more of that information.
Sergio, thank you. You all have a great product there at eBuilder. We're active users, and we certainly appreciate the opportunity you've given us today to speak with everyone around the country and up north. So thank you all again for your time.